Today, we'll be talking about drugs that affect the autonomic nervous system. We've touched on this before. There's several medications that are kind of used across the board for different things. And so some of the ones that we'll mention today, you will have already heard about, or maybe you're familiar with using for something else. But these are drugs that are specific to affecting the autonomic nervous system. What are we going to learn today? Well, there we go. Our learning objectives today is we are going to talk about the major effects of those drugs that work on the autonomic nervous system. We're going to also talk and define what sympathetic stimulation is, give examples of adrenogenic drugs, and give example of adrenogenic blocking agents, so one that encourage and ones that block. We also want you to be familiar with the different classes of antihypertensive agents. Some hypertensive medications work on the autonomic nervous system. We're also going to talk about this is harder to say, cholinergic effects, and we're also going to talk about those agents as well as the blocking agents. Getting started, what we need to know is, what is the autonomic nervous system? Well, we start off with the central nervous system, and nobody writes out central nervous system. They always write CNS. So if you see CNS, that's what they're referring to, the central nervous system. And the central nervous system is what controls all the smooth muscle, the cardiac muscle, the glands. You don't have to think about what they do. The central nervous system takes care of it for you. It controls involuntary actions of organ systems. So you don't have to tell your spleen to produce blood cells or your bone marrow to produce blood cells. You don't have to tell your body to send white blood cells to an area that needs to fight infection. We also don't need to tell our bones to heal. We don't have to tell ourselves to breathe. We just automatically do it without thinking. Now, breathing, can you control? Yes, you can slow down your breathing, you can speed up your breathing, but that everyday working of breathing just happens naturally. So does the beating of your heart. That lub-dub, lub-dub, it's all part of the central nervous system that tells it what to do. We don't have to think about it. Well, this central nervous system is divided up into two parts, and you do need to know these two parts. This is a sympathetic and parasympathetic nervous system. Now, we're going to talk specifically about what each one of those are and what they do. But because you know what prefixes and suffixes in terminology mean, so you probably already know what para stands for. Keep in mind, though, that when you're talking about the sympathetic and the parasympathetic nervous system, they do not work together. They work in opposition of each other. And as we talk about them, you're going to be able to see how that happens. So we have the sympathetic and the parasympathetic. You do need to know these when you're referring to the central nervous system. So I would just memorize them. Central nervous system, two parts, sympathetic, parasympathetic. The sympathetic have the effects of, they work on the cardiac rate and output. So how fast the heart is pumping and how much blood is pumped through the output. They also work on the constriction of the blood vessels, but not just the blood vessels. The sympathetic effect is a constricting effect. So that means that all the vessels that are in your skin and the viscera, when it needs to constrict down, that is the sympathetic nervous system working. Also, when you are sweating, that is part of the sympathetic. It opens and tightens, right? Blood pressure, if your blood pressure goes up or your blood sugar goes up, anything that is going to tighten and increase will be affected by the sympathetic CNS. Also, the only thing that will think of relaxation, everything else is tightened, is the smooth muscle of the bronchi. So it's kind of in opposition. So it can raise your blood pressure, your blood sugar, it constricts and stuff. But when it's talking about the smooth muscle in your airway, in the bronchial passages where you breathe, it actually relaxes those muscles. So of course, the sympathetic system is going to have a major effect on cardiovascular and respiratory. It also decreases peristalsis. It also tightening of sphincters. We have sphincters all over our body. One sphincter that you may not be as common is there at the base of the stomach, where the stomach releases down into the intestines. There's a sphincter, a pyloric sphincter, that allows that to happen. It also promotes urinary retention, meaning that you don't go to the bathroom as much, you don't urinate as much, and dilation of pupils. Dilation of pupils is whoosh, pupils go open, big. You see more black. The irises shrink back, and your pupil is more exposed. What about the parasympathetic effect? It actually is kind of, everything is in the opposite. Like I said, they work opposite of each other. So it decreases the cardiac rate and output. Blood vessels dilate instead of constrict, and lowering of blood pressure. The smooth muscle of the bronchi, it constricts it, it increases peristalsis, and it's a relaxant for sphincters, decrease urinary retention, and it's a constriction of the pupils, meaning it's the pinpoint, it goes down tight. Okay, so there are in opposite effects. With the autonomic nervous system, the sympathetic system, when we think of it, there's a couple things that you need to know, and you need to memorize this. Sympathetic system is fight or flight. Okay, when you talk about animals and they get scared, they have a fight or flight reaction. They're going to get away. Okay, that's what the sympathetic system controls. It prepares people for emergencies. When you get scared, somebody walks up behind you, like that, or you get that panic effect where you look at something, you realize something bad's happening around you. That's the sympathetic system going into effect for your body. On the contrary, the parasympathetic is just the opposite. It does rest and digest, okay? The relaxing, the resting, and the parasympathetic works on maintaining our normal body functions, okay? Normal body functions, the everyday things that we do. The autonomic nervous system, again, these are two terms that you do need to know. We have neurons on the cellular level, and the sensory impulses that are going from the brain to telling us the muscles and everything, the nervous system to tell it the body what to do. That's all through the neurons. And there's two things that you need to know about that sensory impulse, and those are that we have synapses and we have ganglion. Now, synapses, if you look at this image here, the synapses is the junction between the two neurons. So think of these little ends that with the bulb on the end that are touching each other. So you got the two circles right here. That space in between on that graphic that has the little red dots, they're going between, that space there is called the synapses. This is a neuron, this is a neuron, and that junction where all that activity is going between these two, that is the synapses. It is a space or a junction between those two neurons. Your body is full of these. And that synapses is where the activity is happening. Now, what is ganglion? Ganglion or ganglion, that's a group of synapses. So again, this is very minute, you know, you can't see this in our body. This is uh, the so it's microscopic, and these neurons in these parts of the cell that are working together. But when you have a group of synapses, so you have a whole bunch of neurons working together in a cluster, that group of synapses is called a ganglion or a ganglion. And there is preganglionic and postganglionic groups, pre and post. Now, that you don't necessarily need to know, but I'd like for you to commit to memory that the neurons function together using a synapsis, which is that space, the junction, and the ganglion is a group of those synapses. That's how they work. Neurotransmitters, which is chemicals that work with the autonomic nervous system, these neurotransmitters is what grabs and in the synapses. So if you look at this graphic, we have the transmitters over here on this side release into the synapses, that space, and they are attached, the neurotransmitters of the other neuron actually has a receptor that grabs them. So you're releasing and grabbing, and notice those little red dots. There's a pathway in that junction. So again, that's how they work, but there are some chemicals that speed this up and slow this process down. Acetylone is one, and epinephrine, which you're familiar with epinephrine. Remember, we've talked about epinephrine when we've talked about allergic reactions before, and epinephrine's given to, it can work on the heart, and it can also make the body not react. It slows down that reaction when they've had a foreign object or something foreign put into the body, or like I said, an allergic reaction would be those synapses going, haywire. Thus, you break out into a rash, right? So epinephrine would stop that. Okay, so what about the acetylone? How does that work? What it does is it is going to release the postganglion endings of both systems. So you have the one, the synapses in the middle, and you have the one over here and the one over here. One's releasing and one's grabbing, right? Releasing, grabbing. And so it's going to send out postganglionic endings. It's going to release those. It also works with the enzymes. It inactivates these enzymes that help do this process. And this is a real mouthful, so I'm going to try to say it for you. I said it several times last night, and I had it to where I could just get it out of my mouth. And so what we're looking at is acetylone esterase, okay? And we'll talk about that a little more in depth. So the cells that release this acetylone are called chlorinic, okay? So the CH sounds like a K sound. Epinephrine and the non-epinephrine, what they do, they release the postganglionic sympathetic nerve endings just like before, right? We have inactivated the enzymes, but this is a different enzyme. This is a monoamine oxide, so that is a different type. It inactivates that particular enzyme. Not as hard to say, monoamine oxide. So the cells that release the epinephrine, and that's what we want, and the non-epinephrine are called adrenogenic. Why do you think they're called adrenogenic? Because they come from the adrenal gland. We'll talk about that. So what is the autonomic nervous system? When we actually look at it, we start from the brain. That's the beginning of the central nervous system. And then as it goes out, then it comes out through the spine, right? If you look at a picture of a spinal column, a real spinal column, you can go out and Google image it and everything, you'll notice that there's lots of these holes, and these are called not synovial, what are the holes called in the cavities? Sinuses. There's sinuses all through those bones, and those sinuses, which are like little caves or holes, that's where the nerves, the autonomic nervous system, those nerves go out through those. And if you notice here, we've got pre-ganglionic fibers here and here. We've got the spinal cord, we have the synapses, and the post-ganglionic fibers down here. Then we go into the ganglion, which we know a ganglion is a group or cluster of synapses. And then here, the post-ganglionic fibers, which you notice are farther out. What does the junction of the two neurons look like? This is just expanding it a little bit better. This is a different type of picture, probably more accurate than the pretty little graphic that I showed earlier. We have the first neuron, okay, and then you have the second neuron, and then you have that space in between, which isn't actually a void, kind of like that first graphic showed, but this is a synapsis where those little fibers are touching right there, see, and there is an axon. This is all cellular level, all right, that we're talking about, and that axon goes in and touches all of these little receptors. So think of the blue as the little receptors, and then they're passing that synapsis information between the synapses, excuse me. So think of outer space. You got two planets, and there's a big synapsis or space in between them, and you're passing in a spaceship from one to the other, right? Well, what do we need to know about medication that works on the autonomic nervous system? There's 4 ways that medications work on this system. They're going to stimulate the sympathetic nervous system, and they're also going to stimulate the parasympathetic nervous system, and then they're also going to do the opposite. They're going to inhibit the parasympathetic and the sympathetic nervous system. So there's 2 things that they do. It stimulates and inhibits, but it does it both to the sympathetic and the parasympathetic nervous system. So if somebody asks you, what does the medication do to the autonomic nervous system? They say, well, there's 2 parts. There's the sympathetic and the parasympathetic, and it stimulates and inhibits both of them. Adrenogenic. Here's where I told you, remember just a few seconds ago, where do we get adrenogenic agents or adrenogenic? Where do we get that term? From the adrenal gland. The adrenal gland is on top of the kidney. It's this little cap on top of the kidney. And so here's a small picture of the kidney, and this is a larger version of down here of what the adrenal gland looks like. And see how it's connected to the spinal cord? Right, so we have the sympathetic and the non-sympathetic activity going through here, and then the adrenal gland is full of medulla cells. It's the adrena medulla or medulla. I call it a medulla, which is probably not correct. It's probably, they're probably going to hear it pronounced medulla, but I think of the brain, medulla oblongata. It's kind of the same thing. So I say adrenal medulla. I don't know why I do that, but so don't say, well, this is the way she said it, because sometimes I pronounce things wrong. Adrenal medulla or medulla, and it has all of these cells, epinephrine and non-epinephrine cells, all these little blue dots. There's the capillaries, right? The capillaries is that itty bitty tiny finest component of the vascular system where there is a junction between both the veins and the arteries, right? Oxygen passes. Well, so does the epinephrine and non-epinephrine components, and they are all in there in the adrena medulla cells or medulla. What do we get? How do we get epinephrine? Well, epinephrine hydrochloride, when we need to inject that or get that into the body for therapeutic uses, you probably have heard of an EpiPen or adrenaline. The EpiPen is the most common. We've all heard of that. If people are allergic to certain things and they're severely allergic and they have reactions like a bee sting, and especially in the summer, they may keep an EpiPen with them, and that is, that can be a matter of life and death, having the access to that epinephrine hydrochloride. It's therapeutic. It's a vasoconstrictor. It works in the eye and the nasal mucosa. It also works on the for bronchial asthma and severe allergic reactions, because what happens with an allergic reaction? We swell. And you think, well, I could just do artificial breathing for the person. You can't. If a person is having an allergic reaction, that means those pathways, the bronchi to the lungs, are swelling shut. So you can't get a tube or air down there. It is a constrictor. It closes off completely and they suffocate. That's what happens. But if you give them an EpiPen or this epinephrine hydrochloride, inject that into them, and it vasoconstricts and makes the passages open back up. It also is a heart stimulant. The heart will start racing. So they will use that for a heart block, or if a person has acute heart failure and they need to stimulate the heart again, they will give them epinephrine. It is one of the first medications, I don't know if it's the first, but it is one of the first that they give people who have had a myocardial infarction, an MI, or as lay people know of it, is a heart attack. This is very strong medication. It's very powerful. It works extremely fast. That's why it's perfect to use for emergency purposes. And that EpiPen, you just stab yourself with that EpiPen, or you don't really stab yourself. You push it against the skin real hard. You click the button, and a needle shoots out and it injects the medication very quickly, and you start seeing results instantly. Non-epinephrine biatrate is, there are more than one of those. Levofed is the one that is the most common. It's related to epinephrine. It's chemically the same, but it's different. It acts as a vasoconstrictor, and you give it intravenously. Why would you give this? Well, it treats hypotension and shock. So what this means is the blood pressure goes down so low that it's not that you're jump starting the heart the same way that you are with epinephrine. Epinephrine speeds the heart up, and in essence, that's kind of what Levofed does. But when a person, when you go into shock and the body just kind of slows down, it's like, oh, like that. It's a jump start. And so it's similar in that way, but it prevents leakage of drugs into tissues. So they also have used it for that purpose. There are other adrenogenic agents. Aramine has been around forever, and that's when I found this really cool graphic that's an ancient at that medication museum that I've referred to as before. Here's a really, really old vial of aramine, and what this does, it's an adrenogenic agent like the others, but it does less damage to the skin, because you can do it, you can damage the skin, and so it's an extra vasiation when extra avasation takes place. Then Seraphine, this is used mostly for the nose, and it opens up the nasal passages. You can use it intravenously or sympathogenic, meaning shooting it up your nose. It works that way. So what do adrenogenic blocking agents do? Well, it's just exactly the opposite, right? So it's going to, the term they use is nullify the effect. It's going to do the opposite of, it's going to stop the stimulation of the sympathetic nervous system. So again, sympathetic constricts and the parasympathetic opens up. So if we don't want things to constrict, the sympathetic nervous system to all kind of make things shut down and close up, then we would use an adrenogenic blocking agent that would prevent it from doing that on that cellular level. The result is that you get a stimulation of parasympathetic nervous system. So it's literally the opposite, right? So instead of constricting everything down, it's going to make the parasympathetic nervous system activate and open everything up. Well, what kind of drugs are we talking about? Two types. We have alpha receptors, which are vasoconstriction type, and beta receptors. So alpha always means first, beta always means second, or twice. So we have vasoconstriction and vasodilation. Alpha receptors vasoconstrict and beta receptors vasodilate. So the two drugs, that's what they're going to do. Well, blood vessels do those two things. Your arteries are elasticy, and when we need to constrict or dilate them because maybe they're getting older, and I think of a worn out pair of elastic in a pair of pants or a skirt, or that old favorite slip you have. When the elastic is blown and worn out, you have to do something to tighten it up or loosen it up in some cases when we're referencing the vascular system. So this medication will do that. We have a reason for both. The heart usually works off beta receptors and almost no alpha receptors. So beta receptors for the heart, which do vasodilation, opening up. Very seldom do we need to do something to constrict the heart. Very seldom. It's usually we're needing to dilate and allow more blood flow through. And again, they're wanting to give you a heads up. Therapeutic effects vary greatly. So in other words, what works for one person may not work for another person, and different medications in these categories work differently for different parts of the body. So if you're having, you need vasodilation in the legs because of poor peripheral vasculation, then of course that there may be a medication that works better for that than works for vasodilation of the heart. Well, several things that are used for, but hypertension is probably the number one. Then again, there's side effects for some of these. Some cause coughing, and some may cause you to be dizzy and things. The main ones are methyl-dopa, propranolol, and clinidine diazoxide, prazosin, and metoprolol, and nadolol. I highlighted that, made that bold because I actually take that, and atenolol. All of them, notice the OLOL in several of these because they're the same type of medication. So you're going to see that in those type. I don't take we're going to talk about how these can be used for several different things. The nadolol that I take isn't for hypertension. It just happens to be a hypertension medication they use for something else, and we'll talk about that. And if you think about it, it makes sense because what it does, is it a constrictor or a dilator? Now, one more thing that you need to know about is these ergo alkaloids. They're not typically adrenogenic blocking agents, but they do the same thing, so they fall into that class. Aldamet, or the methyl-dopa, is one that you'll see pretty often. They use it as an antihypertensive, so it works to help people with high blood pressure. How does it do it? Well, it interferes, remember in that synopsis, of non-epinephrine and serotonin. So it interferes with the formation. So they're not doing non-epinephrine, and serotonin also works. We know that serotonin is a mood thing as well. Another type is the methyl-dopa, and then they add the hydrochlorothiazide, which is a water pill, and that's alderil. then another one is Inderal, which is propranolol. And how it really works in the smooth muscle of the not only the vascular system, the blood vessels, but the bronchi. So it works for the heart, the bronchial passages, and the vascular system. It's pretty awesome. It decreases the heart rate and cardiac output. Now get that. It decreases the heart rate and cardiac output. Do we have to do that very often? No, we're usually increasing the out rate, but there is um, uh, a need for it, especially when we're talking about the lungs. Catapress, which is clonidine, been around forever, antihypertensive again, but it does something a little different. It stimulates the adrenogenic receptors and then inhibits them. So isn't that odd? It stimulates it and then it inhibits them. Now, Hyperstat, I couldn't find a graphic for that. It's a diazoxide, like how I stumble over that. That's why people call it Hyperstat. It's got some other ones that fall into that category. I think it is an injectable. I'm not perfectly sure. I'm not as familiar with this medication. I did a little research, especially last night, to look to see. I couldn't find a graphic that wasn't very, very old. Directly vasodilates the peripheral blood vessels. So what do we mean about peripheral? Extremities, right? It vasodilates those, and it works in malignant hypertension or hypertensive crisis. Malignant hypertension, if you're not familiar with that, malignant hypertension means that they can't control it. It doesn't mean like we think of malignant as cancer, but think of cancer cells as cells that have gone out of whack and you can't control them. That's how they're referring to malignant hypertension. Hypertension you can't control. It's up and down, up and down, up and down. It's all over. They give medication that doesn't seem to be able to regulate it. And that causes hypertensive crisis. Then we have mini-press, been around forever, also a hypertensive, but it also has a diuretic agent in it, like hydrochlorothiazide. So it's prazosin and hydrochloride, and it can have it produces drop attacks. So you have to be a little careful with that. Low pressor. It works specifically with the beta receptors, and it's going to work in the heart to reduce the blood pressure, which we want, but it also reduces the heart rate and the cardiac output. So we want to make sure that we look at that's why the provider will look at the whole picture when using things like low pressor. Nadolol is what I use, CoreGuard. It is a beta blocking agent. It's used to treat hypertension, but it also is used to treat angina pectoris, which is a type of chest pain. I don't take it for either one of those. You can also make your heart kind of skip, but I use it for migraines. The neurologist gave it to me over 15 years ago because I was having chronic migraines, meaning they never went away. My head didn't hurt as bad as a migraine, but I was having all the other symptoms associated with migraines. And so they said, don't worry, I got a medication for that. And I take a low dose Nadolol and have taken it for over 15 years. I can go 3 days without it before I start getting dizzy, having ringing in the ears, and my vision, gets kind of cattywampus on me. Again, it's but when I was heavier and was starting to have a little bit of hypertension, they just doubled the dose because it also works with hypertension. So now that that's not a problem, I've gone back on a lower dose and it takes care of my headaches. Tenormin, you probably are familiar with atenolol or tenormin, very, very common, and it reduces blood pressure and cardiac output. All three of these medications have been around for a very long time. Ergo alkaloids, I mentioned that, not exactly the same, but they're still a sympatholytic agent, so they still work in the same realm. So you know how we say some medications are used for something else? This works really, really good for obstetric patients, and so it constricts. And then let's see, he say gynergin, no, gynergin, I think is how they say that. It constricts cerebral blood vessels and it treats migraine headaches. Now, I couldn't, this is way too strong for me. They gave me medication, like this, or they give it to you when, kind of like if you got an emergency one. Made me feel like my head was going to pop off. I don't need that. And then we have something that sounds like that, which is ergonovine, and it stimulates uterine contractions. So you might be given this when they're trying to get you to go into labor. Well, now we're into the parasympathetic, and we need to know that this is the chlorogenic agents that I mentioned before. They mimic the effect of stimulation of the parasympathetic nervous system. And again, one thing I didn't mention is we call this the PNS, right? We don't say parasympathetic nervous system. We say PNS, and sympathetic is SNS. I didn't put that in there, but from now on, I'm going to say that because I don't want to keep saying parasympathetic nervous system. Well, one of those is called acetylcholine, and it's inactivated to rapidly, it works on the enzymes. And that word that I used earlier that I practiced again and again so I wouldn't stumble over it for you, acetylcholinesterase, something like that. Okay, you can Google this and hit a button and it will tell you how to pronounce it. It's used for therapeutic use. Synthetic ones will be pilocarpine and neconol. No, there's not another N in there. And it mimics the effects of the acetylcholines. These are ones that inhibit the acetylcholinesterase, okay? Now, why would you want to do that? So here is where I went ahead and grabbed this because I knew I was practicing it. Now, if you learned how to phonetically read things, which I learned in elementary school, had a teacher that wanted to make sure that we learned at a very young age. But so then you could say, instead of it's pronounced E, E or acetylcholinesterase, let's see, acetylcholinesterase. That's how you say it. Anyway, you can go in and click it and it has a little thing. What actually is that? What do you need to know? Well, it's an enzyme, okay? So it's not something that you're going to be talking about. We don't talk about enzymes a whole lot. But what does it do? It causes this rapid hydrolysis of this particular enzyme. It serves to stop the excitation of nerves after the transmission of an impulse. So what it does is you get an impulse, bzz, and it cuts it off. That's what it does. Bzz, cuts it off. Examples of that, well, the one medication is pilocarpine nitrate hydrochloride, and it makes you sweat, the saliva, nasal secretion. So you can imagine why you would use this, right? If you have problems with allergies and things, it constricts the pupils, pinpoints. It works really well with glaucoma, and glaucoma is a buildup of pressure in the eyes. And then there are others. This uroclonine, they use it after you've had an abdominal operation. You have distension and swelling. They will fill your abdominal cavity with air and then they let that out. They try to kind of not necessarily suck that, but they push that out. But also you just have abdominal distension with it, urinary retention and retention of gastric contents. So again, it works on all of this retention post-operative. A really cool one is the second one, but first, progestamine. This is it's going to inhibit this new word that we just learned, and it works on urinary retention and myasthenia gravis. The fun one, though, is this edrophonium Edrophonium chloride. What does it do? Well, it happens to be an antidote for curare. So we think, well, that's great. What is curare? Well, curare is a plant that the Aborigines over in South Africa put on the tips of their darts for poison darts when they want to catch animals, or they may shoot you, I guess, if they don't want you around. So what it does is it increases the skeletal muscle tone, and it is also used for myasthenia gravis, but it is what curare is a paralytic. It paralyzes you. So again, it instead of paralyzing it, it helps the muscle tone go back together. Well, it nullifies the PNS, the effect of the stimulation on the PNS. The net effect, the overall effect, is you get the same stimulation of the SNS. So that's what we want. If we're trying to stimulate the SNS, then we're going to stop the stimulation of the PNS. There's a plant, belladonna. You may have heard of belladonna. It's a poison from way back when. It's a plant that it's very effective. It does some really great things for people, but it's also a poison. So the belladonna plant it produces 3 alkaloids: atropine, which can be used on the heart, cycamines, and scopolamine. What it does is it works to insensitize. It works to insensitive. It makes it not sensitive. The opposite of sensitive, insensitive. I can't talk. To the acetylcholine, thus the paralyzing effect of the parasympathetic nerves. Okay, so belladonna, what it does is it paralyzes. Right, just like the curare, it paralyzes, and therefore you die because it paralyzes the PNS. And if it paralyzes the PNS, then you can't breathe. Right, everything kind of shuts down. Atropine, it's used the most. You'll hear atropine used in the hospital a lot, especially for they'll give you a shot of atropine. Sometimes they use atropine and epinephrine. Heart attacks, and it works on the smooth muscles, but it also works on the glands to help them secrete. It is an antispasmodic agent, so if people are having seizures or spasms for drug reactions and things, withdrawals, they might use atropine to do that. It decreases the serotonin, the secretion with the nose, the pharynx, and the bronchi. So if you're getting so much mucus and everything and irritation, then types of given atropine will dry that up. Will stop it from secreting and drowning yourself with your own fluids. Kind of. Atropine, what does it do? If you get too much of it, these are the side effects. You're going to have the headaches, dryness in the throat and the skin, because it's literally stopping the mucosal membranes from secreting those glands. There's no lubrication. Pupil dilation and dimness of vision. You get flushed skin. The blood rushes to the surface. You get rashes. You get a rising temperature and a rapid pulse. So what do we do if you get too much atropine? Well, gastric lavage, they pump your stomach. That's what gastric lavage is. And the PNS medication is given, and they want your bladder empty. So they will fill you up with fluid and pass it through your bladder. You pee it out, in other words. Librex, pretty common. It is a medication that's a mild tranquilizer, not the same thing as like Xanax and stuff, but it's a mild tranquilizer, but it works good for peptic ulcers, people that have peptic ulcers, and sometimes with colitis, which is an inflammation of the colon, and it's spastic. So again, remember we talked about that some of this takes care of spasms. spastic colitis. This medication works really well with that. It's contradicted with glaucoma and if you have bladder neck obstruction. So if you have anything wrong with your bladder, you definitely would not be taking probably Librux. But glaucoma, because it does the opposite, it builds up pressure, and we want to release pressure with glaucoma. Bentyl, it works really well with irritable bowel syndrome, IBS, and it can also be used with phenobarbital if you have a child with colic. So again, it helps those muscles in the gastric tract. If we get into neuromuscular blocking agents, this is kind of wrapping things up. We're going to, we need short-term relaxation of those muscles. Why would you need that? Because if you need someone to do a procedure like an endotracheal procedure, you want to go down and look at the stomach, and so you're going to scope them. Well, we have an automatic gag reflex, right? We have peristalsis waves that work at pushing things up. Peristalsis waves helps the food go down our gastric tract. However, if it needs to get rid of something, a foreign object, or something that is upsetting the stomach, the peristalsis waves reverse, right? And that's why you throw up, why you vomit. So these neuromuscular blocking agents, they can use this, and it will kind of relax that short term, doesn't take, and that you're able to do a procedure. It's Pavulon is what they use for that. It's very, very short term skeletal muscle relaxant, but it does produce a paralysis, but it's a temporary paralysis. Some other blocking agents that you may or may not be familiar with, again, is Norcuron. These are it does kind of the same things. They're used for procedures, and acididine or quilacin. These are done with these two orthopedic procedures. If they're going to manipulate a knee or electroconvulsive therapy, because you're giving electrical shocks and you need to relax that muscular system, these will work on. But they're very short acting, very temporary, and they last less than 3 minutes. So again, something very, very quick that they're doing. So let's recap. We went over a lot of things very quickly. We explained the effects of the drugs that are used on the autonomic nervous system. We also talked about the sympathetic stimulation that some medications have and how that works. We gave examples of adrenogenic drugs and what adrenogenic, where it comes from, the adrenal gland and adrenal medulla. And then we also talked about the adrenogenic blocking agents, why we would use those. And we also went over the antihypertensive medications and agents, what they would be. We talked about the cholerogenic effects and the how they worked, and some examples of those. And then we also wrapped up with the blocking agents and why we would use those. So I am going to look and see if we have any questions. I don't think we do, but let me just look. Don't have any questions. So again, remember the PNS and the SNS, those two you need to know. There's two divisions of the CNS, the central nervous system, and they control the body in opposite ways. That's really the point, that if you understand that, then the medications that work on each of those will make sense, right? If you need to tighten something up or you need to loosen something up, dilate or constrict, then you would know which system we're working on and which medication would produce that. All right, thank you very much. Don't forget to go to the CCO Club if you have any questions, and you can also ask questions on our YouTube and Facebook channel. Don't forget to like and subscribe. Have a good evening.